Hello everybody, I'm Iriarte and I'm going to show you now the second part of the injuries of the lateral ligaments of the ankle and other injuries. So 2 days ago we saw the anterior talofibular ligament, calcaneofibular ligament, this new ligament, this fibers between the calcaneofibular and the inferior fascicle of the anterior talofibular ligament and the anterior inferior tibiofibular ligament or anterior tibiofibular ligament. It depends on the authors. Okay, and today we are going to check the dorsal calcaneocuboid and bifurcate ligaments and the talonavicular ligament and other related injuries associated with these mechanisms of inversion of the ankle and usually with a misdiagnosis as an lateral sprain of the ankle. Okay, we are going to start with the dorsal calcaneocuboid and bifurcate ligament. We usually talk about these two ligaments together because they are very close, and this is the anatomy, a little reminder about the anatomy of these ligaments. The dorsal calcaneocuboid ligament joins the calcaneus and the cuboid bone, is very thin and wide, and is usually below the pedius muscle, the most caudal aspect of the pedius muscle. And very close, just upwards, the bifurcate ligament has two fascicles, one between the calcaneus and the cuboid, and another one between the calcaneus and the scaphoid bone. Okay. Sometimes there are in continuity. There are not two isolated ligaments, but one ligament which continues. That's why the function is very similar and the mechanism of injury is the same. So it's sometimes like a complex. Okay. The patients will complain about the pain not in the usual area of the anterior talofibular ligament, but just slightly distal and here, distal and inferior. Okay, so you can see here, you can notice the hematoma, but remember that the hematoma is not a useful tool to locate the injury. Something has broken, something has blood, but the location is not very well because of gravity. So we palpate the patient, we touch the patient until we get the pain, the pain of the patient. Okay, and usually is located here. So with x-rays it's not very easy to see this area because in the normal lateral x-rays is the talus is over the calcaneus. We don't have a good view and we need these oblique views, and usually it's not a normal view when we want to check the ankle. Okay, so in this view we can sometimes see something here. With ultrasound, the dorsal calcaneocuboid ligament is very easy to see. We will notice the cortical of the calcaneus here and the cortical of the cuboid here, and it's very important to check that both are at the same level. If both are at the same level, you will be at the dorsal calcaneocuboid ligament. If the calcaneus is more superficial, it's higher, you are in the bifurcate ligament. Okay, as we are going to see later. Okay, always check the both corticals is very important. This area here with this hypoechoic area here is the pedius muscle, and the ligament, the dorsal calcaneocuboid ligament, is surrounded with this fatty tissue, hyperechogenic, and is why when it's healthy it's difficult to see, but when it's injured it becomes thickened and hypoechoic and is easier to see. Okay, don't forget that. Always check the integrity of the corticals, of the calcaneus and the cuboid bone. Very important because avulsions are very common. This is two examples, two patients. Okay, with this, as you can notice, the cuboid and the calcaneus, the calcaneus and the cuboid are at the same level at the same altitude. So we are in the dorsal calcaneocuboid ligament. You can see here the pedius muscle, and another patient with the same image here. Okay, here we can notice very well the ligament. Here is more difficult to see. And what happens in the contralateral, in the affected side? In the first case, here you can notice the avulsion, the bony detachment, this small hypoechoic image here, which is the ligament thickened and is loose, it's not tense, okay, because of the detachment of the bone. So this is a very, very normal image of an injury of this ligament, of the dorsal calcaneocuboid ligament. Here, another example, in this case, with these small fragments of bone. Again, the ligament thickened and hypoechoic, and pain located in this area, okay, an acute sharp pain. This is the video of the first case. Here is the joint between the calcaneus and the cuboid. With some dynamic maneuvers, we can notice this movement. Usually it's very difficult to move between these two bones, and sometimes you can notice this movement when the ligament is affected here. But the diagnosis is seeking the cortical of the bone, these avulsions, or the thickening and the hypoechogenicity of the ligament. Sorry, it's difficult to say. Okay, another example. This is a normal bifurcate ligament. Different. They are not at the same level, so the calcaneus is more superficial and the cuboid is deep. So we are in the bifurcate ligament. You can notice here a good bifurcate ligament, tense, with no edema surrounding this ligament. Very, very sharp contours with the fatty tissue surrounding the ligament. So this is normal, okay? And the corticals are also normal. What happens in the contralateral side? You can notice here in the X-rays something maybe happening here. I'm not so sure, so I performed this ultrasound, and you can see here again the avulsion of the superior margin of the calcaneus. Very, very typical. Another example, in this case the X-rays gives us the diagnosis, but if we take a look with ultrasound, we can see here the ligament thickened, hypoechoic, and with this bony detachment here. We have a very, very good image, an accurate image of this pathology with ultrasound. Very easy to perform, very fast. So use ultrasound. Another example, a patient arrives to our consultation with a lateral ankle sprain diagnosis. Okay, we can see here this hematoma, but the ligament, the anterior talofibular ligament, is quite normal. Maybe a little bit hypoechoic, not sure if there's a good fascicular pattern, but no, it's not very, very important, the changes, okay? And we are going to search other ligaments. This ligament, this is the talus, this is the navicular bone, and this is the talonavicular bone ligament, sorry, between these two muscles, with a good image, hyperechoic, fascicular, no problem at all. Okay, let's check another ligament. This is the dorsal calcaneocuboid ligament, and its image seems normal, but we are going to check from downwards to upwards all the area between the calcaneus and the cuboid bone, and let's see what happens here. And again, in the superior external margin of the calcaneus, you can see here in the insertion of the bifurcate ligament this bony detachment, very, very common, with Doppler and pain just in this area. Okay, so remember, if we check between the calcaneus and the cuboid at the same level, we are in the dorsal calcaneocuboid ligament. And here another example with this ligament hypoechoic thickened but without avulsion of the bone. Okay, so this is a sprain, unique sprain without bone involvement. And sometimes we have the opposite. Here, a big affection of the bone. Okay, so if you have this image, maybe you better ask for a tomography, an axial computed axial tomography, okay, a scan, because it's very important to check the integrity of the joint between the calcaneus and the cuboid bone. Okay, and another patient, we check slightly upwards, different levels. This is the calcaneus, this is the cuboid, so we are in the bifurcate ligament, and a classic example of this thickened ligament here with this bony avulsion, very common. Okay, now we are going to talk about the talonavicular ligament. Its origin is in the neck of the, oh sorry, this is in Spanish, I forgot to translate, sorry. This is the insertion of the head on the neck of the talus, just ahead the recess of the joint, and is very wide, and its insertion is in the middle navicular bone here. Again, we place a probe in this axis. I usually start at the tibia, I go distal, I check the anterior recess till we reach the head of the talus, and between the head of the talus and the navicular bone, all this structure here, this is the talonavicular ligament. This ligament, if we check this article, sorry, 21% of ankle sprains are usually accompanied with this kind of sprains of the talonavicular ligament. In my experience, it's not so frequent. The dorsal calcaneocuboid ligament and the bifurcate are very frequent. I'm sure 20% is a good percentage. But this one is not so frequent, because I always checked all my patients this ligament, and it's not very common to find it affected. Okay, so I'm not so sure that 21% is true. The mechanism is slightly different. A forced plantar flexion of the ankle. So when a patient has a forced plantar flexion, always check this ligament. This is the position, and this is a normal ligament. This is the talus, this is the navicular bone, and a normal ligament. You can notice here the insertion, the proximal insertion, and the distal insertion, covering almost all the dorsal aspect of these two bones. And this is an example of an affection of this ligament, a very thickened hypoechoic affection of the talonavicular with Doppler. This image is very beautiful, but it's not the typical image. It's very typical to see this ligament thickened and hypoechoic, but not so exaggerated. Okay. Again, you can have or not bony avulsions. This is an example, an antique ultrasound with an avulsion of the navicular bone here and this hypoechoic thickened ligament here. Another example, this one with an injury with a bone affection of the head of the talus here in the x-rays. Maybe you notice this fracture, but you're not very sure, and with ultrasound you can confirm this fracture. You can see the thickening of the ligament and the affection of the cortical of the talus. In these cases, I usually recommend to ask for a scan. TAC, I don't know the name. Here, you can see here the affection of the head of the talus. Okay. Another example, this is the bifurcate ligament, and once you have checked a patient with a pain in the lateral side of the ankle and you notice this image here, okay, don't stop here, always continue the exploration. You need to check also the talonavicular ligament, as you can see here, and in this case it has an affection of both, and even with a bony affection here of the talus. So don't forget to check always all the ligaments, okay? Because this is a chop-part affection and a chop-part instability. So very important to check because the prognosis changes. Another example, this is the normal. This is a patient with a lateral ankle sprain with a normal ligament. So we continue, and in the talus, between the talus and the navicular bone, again thickening hypoechoic ligament with a avulsion here. So, and again the affection of the bifurcate ligament here. They are very commonly associated, the injuries of the lateral chop-part and the anterior chop-part, okay? Normal or slightly thickened anterior talofibular ligament, sorry, a thickened talonavicular ligament, and a thickened and with a bony avulsion bifurcate ligament. Okay, we have talked about the ligaments of the lateral side of the ankle, but there are other pathologies which can mimic these sprains because of the pain is very similar and the mechanism is very similar. So once we have a patient, always check, take a look at the patient. If he has a functional impairment 2 weeks after an injury, there's surely not only a sprain. Something is happening here. This is the example yesterday I gave you 2 days ago. This is the example of sock-like edema, and I performed an ultrasound. This patient has a lump, a functional impairment. He couldn't load, and this is the image of the fibula. You can see here the interruption of the cortical with this small hematoma here, with ultrasound with Doppler over this image. So this is a fracture, an undisplaced fracture of the fibula. But there's something else. You can see here the tibia, the anterior tibia. This is the talus, and you notice here this small fracture of the tibia, again with a small Doppler. So we ask the patient an MRI, and this is the image. A fracture of the tibia, which was charging with total load, pain, and functional impairment. We had the lack to diagnose him and to begin with crutches, and the fracture healed normally without problems, but we were lucky. Other examples, this is more frequent, the classic image, we are not so sure this is something happening here in the base of the fifth metatarsal, and with ultrasound we start at the anterior talofibular ligament. Here it's normal. We continue. This is the anterior inferior tibiofibular ligament, normal too. We follow the peroneal tendons. Here is the calcaneocuboid ligament with a good image here, but we are not specifically assessing this ligament. We are assessing the peroneal tendons here, and this is the short peroneus here, and we continue till its insertion on the bone, and you can see here this non-displaced fracture of the base of the 5th metatarsal. Here, very easy to see with ultrasound, okay? And the treatment is totally different. Remember these ring-like or tennis ball-like ankles? Something is happening inside the joint with this effusion, with this recess, with this effusion inside. We need to think about osteochondral damage with bone damage, trabecular fractures, something like that. And the ultrasound is not a good tool. You need to ask for an MRI. But in the consultation, sometimes we will find these images, but very rare, because usually these images are hidden inside the joint. Okay, this is an affection of the osteochondral image of the osteochondral injury of the head of the body of the talus. Okay, and to finish, the peroneal tendons affection. Usually tenosynovitis are not so common related with the ankle sprain. So normally there are other pathologies with other mechanisms. But if we notice this kind of images with this liquid, this tenosynovitis, okay, the diagnosis is good, and you can check the tendons. But there are other pathologies like tears of the tendons or instabilities which are related with the sprain. Maybe because the sprain causes this pathology, or maybe because this pathology was here but was not symptomatic, and the sprain makes this pathology to begin to provoke pain. Okay, so this is an image of a tear inside the long peroneus here, and this huge affection here. So this is chronic. This is not an acute image of a peroneal tendon injury, but the sprain, with the sprain, it began to be symptomatic. Okay, so always check other structure. This is the Doppler of this image here, and this is an example of instability. There are several types of instability. This one is with the total luxation of the short peroneal tendon here. You can see here the rupture of the retinaculum, the superior retinaculum of the peroneal, the superior peroneal retinaculum here, and the tendon thickened, hypoechoic, and totally out of its place anterior to the fibula. Okay, so the instability must be checked, assessed when someone complains about pain in the lateral area of the ankle. Okay, that was intense, but we have finished. Remember, go further and check all these ligaments. It's 2 minutes, 3 minutes of your time, and they worth it. Okay, because they are very common, these injuries. My name is Iriarte. I hope you have enjoyed this video, and if you want, just check the like and subscribe if you want notice to be warned in other videos. If you have questions, you can post in the comments. I try to answer all the questions if I can. Thank you very much.